Hello, I'm Dr. Brian Hodges. I'm the Executive Vice President, Education and Chief Medical Officer at the University Health Network and a Strategy Advisor for the AMS Healthcare. Really pleased to join you today with this outstanding panel that I will introduce to you in just a moment. Before we begin, it's important to begin with a land acknowledgement. I'd like to acknowledge that the Indigenous peoples of all the lands we are on today need some consideration from us. And in the virtual environment, it's a special task for us. We're not in one place. We're all over this great country, and many of you may even be outside of the country. So when we meet on a virtual platform like this, it's important we take a moment to acknowledge the land we're on, the land we call home, and the land where we work. We do this to reaffirm our commitment and responsibility to improve the relationship between nations and improving our own understanding of local Indigenous peoples and their cultures. From coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nation people that call this home. So as we proceed to talk about the voices of patients and families and others, I do want you to give thought to the origin of all of those who occupy and practice and live and thrive on this land. Now I'd like to introduce the panelists to you, and you'll hear from each of them in a moment. I'm going to give a very brief introduction to each, and then following that, I'll invite them one at a time to give a sort of 3 to 5 minute overview of their perspective on our topic today. And of course, our topic is how to make real advances, how to make this happen, how to change the system and ensure that we're making a real difference in the experience of patients and families and valuing all of the voices that can make healthcare better. First, I would introduce Dr. Sandy Buchman. He is the past president of the Canadian Medical Association and the Freeman Family Chair in Palliative Care at North York General Hospital. Elise Maybee is a patient and family advisor and co-chair of the Community Engagement Council at St. Joseph's Health Centre. Heather Thiessen is a patient advisor and a surveyor with HISO. Roberta Timothy is an assistant professor at the Institute for Pandemics at the University of Toronto. And Susan Fitzpatrick is the former Associate Deputy Minister of the Ontario Minister of Health and interim CEO of Ontario Health. I welcome our panelists very warmly. We're lucky to have this very gifted group of people with us for the next hour and a half. And I'm going to turn to them one at a time to give an overview on their area of interest before we launch into a cross-pollination between the panelists. So first I'll turn to Dr. Sandy Buchman.
Thank you, Brian. It's a pleasure to be here. And I really appreciate the opportunity to kind of reflect on these questions. And so I came up with a couple of my own questions here to address. And I'm starting with what actions are needed to achieve a compassionate, technology-enabled healthcare system? And the second question I reflected on is, how do we get providers to recognize and value compassion in their interactions? So regarding the first question about what do we need to achieve a compassionate technology-enabled healthcare system, I think there are two main ways to influence physicians and other providers about how to value and integrate and embed compassion in their day-to-day interactions with patients. Firstly, it's really important to get the messages out that compassion matters. Compassion care is vital for healthcare quality. There's significant scientific evidence around the benefits of compassion, which includes improvements in clinical effectiveness, patient safety, cost effectiveness of care, the health, well-being, and engagement of staff, and there are many more. Physicians and other healthcare providers believe and practice evidence-based medicine, and the data speak loudly. This is not conjecture. Clinician scientists like Dr. Stephen Trzeciak and Anthony Mazzarelli in their 2019 book, Compassionomics, lay out all the evidence. They undertook a systematic review of the world biomedical literature and demonstrated that compassion matters for patients, for patient care, and for those who care for patients. And this data isn't just what scientists like Trzeciak and Mazzarelli think, nor what they believe. Rather, it is what they found. Compassionate care belongs in the domain of evidence-based medicine. Physicians are open to integrating data and evidence-based medicine into their practices, and the evidence is convincing, but has been slow in its uptake. Why? Well, perhaps it's because it's not completely intuitive to believe that the quality of human interaction can be measured and demonstrated scientifically to have impact. It is not yet fully integrated into medical education, given the competition with so many other areas, including the allure of remarkable technologies. As Dr. Brian Hodges has espoused, effective healthcare requires more than expert knowledge and skill sets. Utilizing knowledge and skill sets, including technology, require their delivery and implementation through a compassionate care approach. The evidence speaks volumes, and doctors listen to evidence. So thus, I think it's one of the ways to achieve a technology-enabled healthcare system. You have to educate physicians about the evidence that supports the integration of compassionate care. But it's not the only way. That second question, how do we get providers to recognize and value compassion in their interactions, is also critical. I think that one of the ways to get providers to recognize and value this compassion is to allow them to experience it themselves. And how do we achieve that? As most people are aware, burnout is extensive throughout the medical profession, as it is with other healthcare professions. A toxic work culture environment often contributes to this outcome. So an important way to influence culture in medicine is to change that culture through a compassionate leadership approach. You set the tone at the top. If the culture in which physicians train and work can be a supportive, compassionate one, evidence shows the way physicians' practice is greatly altered. They begin to value how compassion not only leads to better patient outcomes, but work becomes more rewarding and enjoyable in a supportive, team-based culture. Compassionate healthcare system culture permits patients to feel safe, their dignity restored and preserved, and it does the same thing for providers within that system. It helps address burnout, depression, and psychological distress of clinicians. And then their higher quality care reflects that compassion and also reflects improved competence. Clinicians also begin to demonstrate the characteristics of effective compassionate leaders, including connection, caring, using mindful, intentional words and behavior. They demonstrate integrity and become much better listeners. These characteristics and behaviors enhance trust in the doctor-patient relationship. And make no mistake about it, effective healthcare is based on trust between patient and physician. Without trust, there is no effective healthcare. Even as AI takes over diagnosis and therapy recommendations within medicine, the interpretation of that information provided by technology, its implications, and its implementation can only be effective if the patient trusts the physician and his or her interpretation and recommendation of the information. The trusting relationship of patient to physician has never been more important. We are all humans, patients and providers alike. Healthcare providers require a compassionate approach as well. That's another way to get providers to recognize and value compassion in healthcare, is to have them work in a compassionate, supportive culture, enhancing trust, facilitated by compassionate leaders, and experience the benefits of themselves as human beings. Thank you.
Thank you so much, Sandy. We'll now turn to Elise Maybee.
Yes, well, thank you, Brian. And I just want to point out I'm the former co-chair of the Community Engagement Council, just to set the record straight. I'm really excited to be part of this discussion today because I am completely a fanatic for digital health. And it's a subject very dear to my heart. So since 2011, I brought my experience as a patient, as a remote caregiver for my mother who was in the Dutch healthcare system, and as a former designer of software systems to being a patient partner. Leadership in healthcare is not, in my opinion, exclusively the purview of the mucky mucks at the ministry or healthcare organization leaders. There are leaders among patient partners, and we have heard from some yesterday and today. Like many, there are more waiting in the wings. So there are three things I wanted to sort of touch on today, and that is, first of all, that I think patient partners are really instrumental into where we're going with all of this, and indeed could be leaders. Firstly, in the move to virtual care and increased digital, this move is going to challenge and it's going to change the nature of the provider-patient caregiver relationships. And in order to look at that in another way, I'd like to suggest that we think in terms of patient flow and not just provider workflow. I think we need to look at flows from a patient perspective that support patients and then dovetail them with provider workflow. And in order to do that, we're going to need a wide diversity of patient partners that should be involved in this work to co-create enmeshed flows. And I think in that process, while we learn about each other's challenges and we learn about each other as humans, that listening and learning is a step towards compassion for each other. I do believe that the compassion needs to be a two-way street, because I think it will be very challenging for providers to move into the digital world, and they'll need the compassion of their patients as they do that as well. So for me, patient flow is a very strong consideration, and we should really pay attention to that. The other thing I wanted to talk about is the systemic changes. They're going to happen. They're going to barrel along with or without patient partners. And what I worry about is that the expediency and the old familiar is going to trump, in my opinion, the very necessary rethinking of the system and data access. We have seen with COVID the absolutely disastrous inequities in our system, so that has really shone a light on some of the things we need to take care of. Patient partners can and should be part of any efforts to redesign systems and data access in order to remove those systemic barriers to compassionate care. The final point I'd like to make is the public. The public will need a lot of communication, education, and support to come along for this ride. Without the public, there is no healthcare system. So please let's keep that in mind. And who better to determine what should be done to educate and communicate with the public, to support the public, than patient partners. The public should never be seen as the passive recipients of care, but as active participants in thinking and rethinking our health system. So let's make sure that the public vote knowingly for changes in healthcare. And this, I believe, will free providers to provide the compassionate care that they signed up for and that we all want. So in short, I think patient partners can take leadership to design patient flows, to be involved in the design of an equitable system with consented access to data, and most importantly, to ensure that the public are not left in the dark, but that they become knowledgeable participants in the changes. Patient partners need to step up, but without a place to step to, we are limited in the actions that we can take. Thank you.
Thank you, Elise. We'll now turn to Heather Thiessen. Heather.
So much, Brian. So I am from Saskatoon, Saskatchewan, and I'm also, I should clarify as well, I'm co-chair of our provincial Patient Family Leadership Council. I'm also I'm an ill patient. I am chronically ill. I deal with 2 chronic neurological conditions, MS and myasthenia gravis, and have spent most of my life as a patient in our healthcare system. I also have another role as a family caregiver to my mother-in-law, who is 94 years old. She has some minor health issues and lives in a seniors care complex home. Patient family-centered care is just the way we do things here in Saskatchewan. We did an incredible amount of work after the patient first review in 2009, where we really moved from a system-centered approach to healthcare to one that included and recognized that most underutilized voice in healthcare being that of the patient, family, and caregiver. Culture change is difficult and was difficult, but to see how together we could change for the better was so worth a lot of the obstacles that we had to encounter. In my role as co-chair of our Provincial Patient Family Leadership Council, we sit together with our leadership in the province, in our health system, to really partner, to lead, connect, and partner to really ensure the voice of patients and families is woven throughout the work in our healthcare system. It is with that authentic engagement and really valuing that voice of patients, families, and caregivers, we have seen some incredible differences in how care was received and really bringing care and compassion back into healthcare. And to be honest, is that not what is this all about? COVID-19, though, really illustrated how, to us in a flash, how we could go back 10 years and bring back some real paternalistic ways of thinking. And that the voice of patients, families, and caregivers were all but forgotten and were not included at the table for discussion, especially with subjects pertaining to us as recipients of care. It really made me sad as a patient partner for so many years of growth and learning were gone in seconds. I have heard some really sad stories from patients writing to our health systems, and I'm sure you've heard them over the past few days. But one that hit me very hard was from my own mother-in-law when she said, Heather, she says, I have never been asked what I want. I am 94. I have lived a good life. I would like to have a choice in what I make of my final days and how they can be happier. I have never been asked what I would like for dinner or when I would like it to come to my door or who I have dinner with. But even more so, I would like to have time with my family, and that is being taken away from me as well. When I hear comments like that, I am just filled with sadness. We need to bring compassion back into our conversations, and every one of us plays a role in that. We need to go back to those basic rules of engagement and being open to voices of those involved and ensuring they all have a seat at that table. Technology can help us and make it easier to connect, but if we still forget that voice of patients and families and caregivers, we will never have that compassionate care back in healthcare, and we will be back to square one again. So how do we respect that voice of patients, families, and caregivers? Not just when we are remembered, but how do we ingrain that in our DNA, focusing away from what is the matter with you to what matters to you? So how amazing would it be if our health ministries, both federal and provincial, took the time to really tap into that wealth of knowledge and lived experience of patients, families, and caregivers across Canada. When I first started many years ago, and Elise would know this, there were very few of patient partners, and this has grown exponentially across Canada. And we are so willing to give up our time and have a real vested interest in helping. And I know we would see some amazing creative conversations on way to build compassion back into healthcare through authentic conversations. Wouldn't you rather hear criticism in a safe environment than to read it in the paper or see it in the news, as we did see at the beginning of COVID when some of our seniors' homes and how elders were left alone and dying without their loved ones. No one deserves that, and we must do better. Thank you.
Thank you very much, Heather. We'll go now to Roberta Timothy. Roberta.
Hi, Brian. Thank you. I'm going to first locate myself in the conversation. So I identify as an African diasporic woman as feminist, surviving African enslavement from a working class background, daughter of immigrants via the Caribbean, mother of two, living and resisting with a visual disability, a corneal disorder, in Turtle Island, Canada. I'm an educator, researcher, community organizer, and therapist with over 25 years of intersectional anti-oppression and anti-colonial praxis experience. I was raised in the feminist movement, anti-violence movement, women abuse shelter community, now called intimate partner abuse. I began to work in anti-violence shelters at the age of 15. I also grew up in Pan-African movement and the anti-apartheid movement in Canada, supporting social justice and compassion work for South African peoples as a child, and anti-racism and anti-oppression praxis in Canada. I've worked with complex trauma survivors in shelters, hospitals, agencies, community health centers, worked with children, youth, families, women, men, trans, two-spirited communities. I've been a patient. I come from a local and transnational family, and I also am a caregiver. I just want to put a little bit of context here first before COVID-19. So system-level leadership is needed to support families who have historically and currently experienced health inequities and health disparities. African, Black, Indigenous, and other communities who have experienced what I call health violence. Before COVID-19, these communities were dealing with a strained relationship with the healthcare system, often experiencing racism and other forms of oppression while seeking healthcare services, working in healthcare, or studying in healthcare programs, or disparities in trying to get into healthcare programs. Example, med school, psychology, and public health, to name a few. The results of the impact of anti-Black racism and other forms of intersectional violence have been devastating impacts on health of Black and Indigenous communities, resulting in higher rates of chronic health conditions such as diabetes, high blood pressure, HIV, etc. Also, the lack of race-based data and lack of health research based on Black communities and the impact of racism and other intersectional factors on our health are also an issue. Now, during COVID, this increasingly COVID-19 has intensified inequities already existing within our healthcare system. As of mid-August, 83% of reported cases have been identified with racialized groups, 22% from the Black community, which accounts for only 9% of the city's population. I say this because when we're looking to do action, what action is needed and what in terms of a compassionate, digitally and AI-enabled healthcare systems, we also need to know the context that we're in. And I have a few suggestions. So the action that is needed, one, is to understand that health inequities and health disparities exist within our Canadian healthcare system, and that these disparities existed before COVID and are intensified now. Two, all digitally and AI healthcare systems need to ensure that these communities, Black, Indigenous, and marginalized, are not re-traumatized or harmed through their digital platforms by ensuring an anti-oppression practice and training be a high priority. Also, having health professionals from Black, Indigenous communities as part of the digital healthcare team in the development and implementation plan of care is critical. Number three, to make sure that the platform is accessible based on inequities and resources, i.e. not everyone has a computer or internet service. How can the platform be made for communities who do not have the right equipment? Some suggestions are providing community members with accessible access to computers and internet and online training, and also have phone-based components. How do we make digital health technologies work for patients, families, and caregivers? For patients, we clearly need to outline patients' rights from a health equity lens on the digital platform, and making sure that there's a disciplinary plan that is implemented if patients experience any form of racism and other types of intersectional oppression, health inequities, etc. Access to digital equipment and training, including accessible technology for elders and people living with disabilities, is critical. In terms of families, we need to make sure that all heterogeneous types of families are welcome and are part of the digital and AI experience from a cross-cultural perspective. For example, including sole parents, same-sex or gender-fluid families, and racially diverse families are included in the healthcare model. For caregivers who are disproportionately racialized and women, often coming from working class backgrounds, so providing relevant supports from culturally diverse perspectives, including mental health from an anti-oppression lens, is needed in the digital platform. Also, doing an audit on the needs of caregivers and technology is important. I'd just like to end in terms of looking at our kind of notions and definitions of compassion. Compassionate digital and AI healthcare means meeting people where they are and including their experiences and valuing their knowledges and ways of being with respect, dignity, care, humility, while practicing a health equity, anti-racist, and anti-oppression framework. Compassion should never cause harm, and the goal is always about providing comfort and support to those who are dealing with health dilemmas and health inequities. Thank you.
Thank you very much, Roberta. I just know, Roberta, your microphone is a little bit faint, so maybe as we go into the questions, maybe there might be a distance issue to adjust there. Thank you, but that was very clear and helpful. Thank you. We'll go to Susan Fitzpatrick next. Susan.
Hi, thanks, Brian. I'm going to give a little bit of my context. I think Brian did introduce me. I've had 40 years in the health system. I was at the Provincial Ministry of Health, the LHIN, and more recently in Ontario Health. But personally, I'm a daughter, a mother, a wife, a friend, a sister, and I have experienced the healthcare system up front and personal. I'm now a patient and family advisor at Kingston Health Science Center, and I'm blending experience I've gained in my professional capacity over the last 40 years with my personal experience in the health system. So, in terms of how do we make this happen? Like, what do we need from our system leaders to create a new compassionate, digitally and AI-enabled system? And I would say, to begin with, system leaders at the provincial and local level need to support a fundamental change on how care is delivered. And I would argue that this has not been seen since the inception of health insurance in the 70s. That system was designed around healthcare providers, at that time primarily physicians and hospitals. The design of a new system that is compassionate, virtually enabled, and data-driven needs to be co-designed with patients, families, caregivers, and health providers. A co-designed system is one that works optimally for all participants. I think there's an opportunity to rebalance roles and responsibilities as patients are digitally enabled to contribute to their overall health and wellness. New modalities will give individuals information to manage their health that go well beyond what is traditionally found in the health system. So that's my first point. And I think by really redesigning the system with all the important partners in it will bring the compassion into it. Secondly, I think system leaders and educators need to take a close look at the workforce of the future and how we prepare healthcare providers for success. Jobs are changing and new jobs are going to be created. And how are we managing those transitions at the organizational level? And how are our educational institutions supporting people to take on new roles? Thirdly, I think as we embrace the benefits that technology can bring to healthcare and overall health, and this is a point I have in common with Roberta, I think system leaders must recognize that it is not universally accessible for all. It's not a one-size-fits-all design, but rather we have to create options and adaptations to individuals with different needs so that we do not create greater disparities. I think inclusivity is so important in this, and this is something that we could really lose compassion if we design a system that does not include everyone. The health system of the future that is technology driven will need to be able to communicate frequently and through many different mediums. Too often communication is lacking, and it needs to be seen as an integral part of the healthcare experience. A lot of feedback I have from friends, family, and so forth is they didn't get the information they needed. And I think this communication is a vital part of the experience, and it needs to be created with patient partners. Finally, I would say that health system leaders can lead by creating and modeling the new normal. A digitally and AI-enabled healthcare system is not one where digital technologies are simply appended to the existing system, which is largely a face-to-face bricks and mortar system. It is imagining a health system that brings together the best of each system, and the sum of the parts is greater than the whole. So what do I mean by this? And I think in the questions and answers, we may get a little bit further into it. But when I think about compassion, the system of the future, I mean, we can create a system where there's no more long waits in waiting rooms. Can we eliminate waiting rooms? No more consultations with missing diagnostics. So the point of the consultation has been missed. Less time and cost of travel. For some people, that's prohibited. And I could go on and on and on. And I think if we imagine that system, we're going to bring greater compassion into the system than we've ever seen before. So thank you, Brian.
Thank you, Susan. That's the perfect way, because we are going to imagine a better system. A lot of the people participating today and who will join the question and answer are going to ask for some specific granular details, I think, and will probably challenge us as leaders, and you're all leaders, about what we can actually concretely do. So I'd like to go there first. On November 18th, AMS is releasing a book called Without Compassion, There Is No Healthcare, in which an argument is made that it's really the optimal alignment of human compassion and the right digital and technological approaches together that will extend the human compassion and the human imperative for compassion. So I want to ask each of you, Susan, you started into this, but I'd like to go a little more granularly and ask each of you a very pointed question. If we're going to adopt technologies, technology is quite a neutral thing. Some of them will be perhaps fantastic for improving the experience of patients and families and compassionate, and some of them might be absolutely atrocious. I would draw your attention to the, please press 1 for this, please press 2 for that, and then eventually you're just disconnected and hung up on. That would be a horrendous example of technology and compassion, whereas I'm aware in one of our clinics, there's a lovely example where we have switched from desktop computers, no longer turning your back on patients, but sitting beside the patient, gazing at a laptop together to look at your images and discuss your care. I would like to invite each of you to give an example, a very concrete example for the listeners of something that you have seen, experienced, heard about, witnessed, been reported about, that is a technological intervention or advance that extends compassion. So I don't know who wants to start, but I think it would be very interesting to pull apart some very specific examples. Has anybody got anything they'd like to speak to that is of that nature?
I can just suggest one. I think, specialist visits where there's ongoing monitoring of a patient, I think can be very successful virtually. And I've experienced that myself, but I think part of the compassion in those visits, I think people generally feel that virtual care, if it's not face-to-face, can't be compassionate. But in fact, those visits sometimes can open up the relationship. The specialist can see the person in the home, the family can be more involved. So I think that the compassion comes through that way. And in many times, there doesn't need to be, with a person maybe that's sick to, get them out of the home to a physical appointment. So there's compassion in that. And that goes a little bit to what I'm saying about communications, like how can we look at those virtual interactions as something that is compassionate, although there isn't a face-to-face connection.
I like the fact you're drawing attention not only to the traditional idea that compassion is what you and I are sort of virtually doing. I'm looking in your eyes. I don't know if you're looking in mine. We're online. There's certainly that element of compassion, but you're making the point that a system that is designed not to require you to travel hundreds of miles and pay $25 of hospital parking is compassionate in another way. So the broad definition of compassion. I love that example. Other examples from others of things that you've experienced. Alice.
Yeah, so I'll just tell two stories. One is I had the experience of going to an urgent care clinic just a couple of days ago. And my interaction with the physician was virtual. And there was this huge screen in front of me. And I went because I was really concerned and I needed some reassurance that things were going to be fine. And I could see his face, which was larger than normal. And he was really wonderful. And I left feeling like I got the information that I needed and that I was really reassured. So I think it's possible to have an interaction like that, especially on a big screen. I mean, I'm looking at everyone here and you're very small, so it's a little harder. But in a big screen environment, I really felt that. And I really felt his compassion coming through to me as well. As a human. So that's the first thing. The second thing is that I've had the privilege as a patient partner to team up with a group of people at Women's College Hospital here in Toronto. And they have a program called COVID Care at Home. And it's designed to, through digital supports, help people stay at home to manage their COVID symptoms. And COVID is really scary. We don't know, if we get some symptoms, we don't know what it means. We don't know where we're going to go and so on. So I think people sort of really want to be reassured and handheld through the experience. And this program basically does that. From the assessment center, you are then sent home, but you're sent home with the ability to connect digitally. And I can't remember all the details of the program, but they included not just physicians, but social workers and the like. So there were allied health professionals of that sort. And they ended up actually being, in some senses, the bulk of the support that patients needed to stay at home. And the statistics that I saw the last time I was at a meeting were very, very positive. People stayed at home, they managed their care, they were more relaxed, and so therefore they could focus on it, and so on. So I thought that was wildly successful, and I asked the question, can't we do this for other types of things, not just COVID? What about other chronic conditions and so on? This level of care is unbelievable. It's really great and very compassionate, because they also helped people deal with how do you strategize being, you know, isolated when you have a roommate, for example. All of those things that are really part of the nitty gritty, but aren't, you know, sort of really healthcare, if you will, but they are in fact impactful. So that's my example, and I'm very encouraged by it.
Elise, I'm going to jump off this into a nuance on this question. So, you know, I think each of us can think hard about those technologies that we've enjoyed. You said that in this example, I'm just going to warn you that my computer is saying it may restart. So I'm going to just in case that happens. Elise, you will become the chair.
Oh, great.
That's really strange. Technologies, you know, actually, one of the cognitive issues that's required for all of us, and I'm a clinician who does virtual care, is actually staying calm and dealing with the vagaries of technology when they do strange things. I did want to jump off this because I think we can imagine the qualities and features of an empathic experience, of the picture that you've painted of the head of the clinician looking at you is important. And I think patients and families know that. My next question is going to be, as leaders, how are we involving patients in the procurement, the purchasing, the design, and the installation of all these technologies? We know from counterexamples like electronic patient records and other things, this is not always easy. Could I maybe ask, who shall I ask to start with that? Heather, could I ask you, do you mind if I pick on you for a second? You're from Saskatchewan, the home of the entire healthcare system that we enjoy in Canada and feel very proud about. As an advisor and a patient and with experience, how do you have a voice in what kinds of technologies the Saskatchewan healthcare system spends a lot of money to purchase? How can that work?
You know, it works really well. And, you know, as I said in my example, you know, when COVID hit, we kind of went back, but we slowly brought in the voice of the patient again, and we realized, boy, that was just the wrong thing to do. So we ensure that with everything that we're doing, from policies to bringing in different technologies, we're ensuring we have a patient voice on all that. And that just becomes standardized within our province, that we're ensuring that we're listening to and honoring the different perspectives and the different needs of patients and families throughout our province.
Roberta, there are some criticisms of the way that people are chosen to represent the patient voice, for example. And we know, and you've said it eloquently in your opening remarks, that there are populations of patients much more affected by certain conditions. Let's stay with COVID for a second. And we don't always give as much thought to the representativeness or the diversity of the voices that we hear. And you've suggested this very powerfully in raising, I think, a question about whether technology will make this better or worse. There are populations, I think I could choose many, but I would direct us to the Indigenous population that we started with in the Atlantic acknowledgements, who don't have access to the same technologies. What would you say, Roberta, would be your advice about how to think about ensuring that really a wide variety and diversity of voices are heard and are participating in these choices of technologies, of what is helpful, what's not? Yeah, could you comment on that?
Yes, Brian, thank you. I think that, you know, even when we're talking about patient boards and patient representation, which patients are we talking about? Which patients are not represented? So we need to make sure that the patients that represent patient care and patient needs are diverse patients, or patients coming from communities that do not have health disparities, but also have a lack of trust in the healthcare system. So we have to do some work in, getting to these communities and communicating in ways that people feel safer to join these conversations. And many folks will say, I don't want to go, I'm not going to go to the hospital. And that's one of the problems right now with COVID, is that based on the past experiences of health disparities and health violence, folks are not coming for even issues where they need to seek care. They're not going to come, and that is going to cause more health problems or health issues. So when we think of what the patient is, who the patient is really critical, and we need to not only talk about how do we have compassion, but who are we having this compassion for? Things such as racial profiling that happens. Some folks are racially profiled in hospitals or clinics, right? What's going to happen online? We know that the social media and the internet has a lot of problems. We know that people have been bombing Zoom, in terms of racist and other oppressive pieces. How are we going to make sure that doesn't happen? I think that, the kind of method in which the digital platform, we can talk about many, I taught health informatics, the different ways of collecting data or sharing health records and sharing that importance of being digitally together. But I think it's more important, how do we teach people, practitioners, to be empathetic, to be compassionate, to understand that people will do things differently and work differently. As a psychotherapist, my practice has moved online, and how I engage with folks is really, really critical. My tone, my listening, how I actively listen with them, what I say to them. So there's I don't really think the platform it is an issue because some people have access, but more importantly, how are practitioners responsible and accountable for not causing harm and to really create inclusion within the work that we're doing. So yes, there are people who need resources. We need to think about, what funding are we going to have for people who don't have resources to get computers and systems. But we also have to think more importantly about what are we actually going to do and how do we cause, an equitable, safe environment for people to seek services.
Thank you. I'm just going to trust my computer, which tells me I have 3 minutes and 52 seconds before it restarts, and there's absolutely no way I can stop it. So I'm going to seriously tell you that if I do drop off, you will need to transition to the question and answer, which follows this. I'm going to ask Sandy a quick question about trust, because you used the word trust, and Roberta is talking to us about the fact that our system is fundamentally built in ways that huge swaths of our patients and families don't trust the system, to the point that they don't even want to come to the hospital. How does an organization like the Canadian Medical Association or the Canadian Nurses Association or our professional societies help us move to a place where we can systematically build trust, recognizing some of the big gradients that work against trust and compassion in the system?
Well, thanks for the question, Brian. And it's a challenging one on a system level. But I think the answer lies, and one of the things we are absolutely doing at the Canadian Medical Association is addressing each of the issues the other panelists brought up here today. So an example, we've just developed a full equity, diversity, inclusion policy. That's not only for the health profession, about who gets into the health profession, but it's also about how we connect to patient, recognizing the importance of structural racism, as an example, within the healthcare system as one of our most important public health issues, but that the associations have to represent the diversity of the population. So our membership, who gets into medical school, for example, who become physicians, is really critical. We are working with, on a system level, for example, with the Black Physicians Association of Ontario and with the Indigenous Physicians Association of Canada in order to mentor even high school students to consider a career in medicine. We also have in the CMA, we have the patient voice. We work very closely with patient and family advisors, and they contribute to our policy development from the ground up. I remember one concrete example when I was president of the College of Fine Physicians of Canada. I have something called the Social Accountability Working Group, and this comes because I do work on the streets as a palliative care physician, dealing with the more marginalized populations. And one of the things we did was we brought on people with lived street experience onto our committee. It was the first time that any kind of medical association actually brought it, because we needed their point of view. We needed their lived experience. And not only that, we supplied them with the technology, which as the physicians we all had, but we supplied them with computers, emails, phones, and they were paid in order to have a better level playing field so that they could actually participate in what the rest of us were doing. So it's just a couple of exampple of what we're doing these days.
Terrific example. In the 1 minute I have left before my computer kicks me off, and honestly, I think it's a lovely metaphor for the powers that technology have over us. However, it's exactly the right time because we want to transition to a robust discussion with our audience participation and the Q&A. So I'm going to just take a moment to say a very warm thank you to the panelists for this part of the discussion, and we'll now transition to an open question and answer with members of the audience, and we welcome your difficult, challenging, provocative questions. Thank you very much. Hello, everybody. We're really pleased to be back. I think if we were pretending to do the magic of television, we would lead you to believe we never left. But of course, a few days have gone by, and the happy news is my computer did shut down at the end of the conversation, and all was well, and we are back. It did actually, for me, represent the challenges and controls that technology really does throw at us when we're working in this environment. The other wonderful thing that's happened, life goes on, and in a few days since our last encounter, those of us on the panel who didn't know each other all that well have got to know each other a little more deeply. And as I introduce each of the speakers to participate again this afternoon, I will ask them to elaborate a little bit more on some things that we've come to learn about each other. They also asked me kindly to say something more than I had a job in a big hospital. And I did want to share with you two things. This is a very personal topic for all of us, and many have expressed that. I have been a caregiver throughout COVID, and I unfortunately lost my mother about a month ago, and she was in long-term care, and I was one of those family members who was not allowed to see my mother for 4 or 5 months during the first wave, and that's very hard. Fortunately, I did spend 2 visits before she passed, and there was a chance for me to reestablish the connection. But I think for all of us, we recognize, and it was spoken about very eloquently by several panel members, we did some things wrong in the first wave, and we need to counteract that. The other side of that, though, is I'm a clinician, I'm a psychiatrist, and I'm doing my best now, several months into COVID, to connect to my patients and families over technology. And I'm learning about that, just as we're learning to do things like this panel. And some of that is going extremely well, and I hope that we will pick up on some of those things. But someone also mentioned last time how hard this can be on the providers. I think it was Sandy who talked about the fact we're all human. And I tell you, after the end of a virtual day, I'm missing something. I am starving a little bit for that hallway conversation where I just say, how are you, to my colleagues? So these are some themes that I think each of us will draw out. And as I turn to the panelists, I welcome back to each of you and I'd invite you to add any nuances or more details about yourself and this work. The questions are coming in on a separate screen. It's not, you might wonder if I was not making eye contact with the speakers in the first session. And in fact, I was making notes and things. It's another thing you have to talk about in the virtual world. So to my left is my iPad where I'm scrolling questions that are being curated for us during the Q&A. And it's terrific because we prepared some and many of them are here. I did want to deal with one right off the top just before we get going because it's an easy one and it's a great question. And it was, what is going to happen with all this amazing feedback and conversation that's been going on for 2 days? And the AMS colleagues tell me that what will happen is it will be compiled into a manuscript syllabus recording with recommendations, very important, I think, and pivotal recommendations from this Congress that'll be put together and will appear in the new year. So this will not be lost. It's not a one-shot, one-time. It's definitely something that we will learn from and celebrate and promote. So to get us started, and there's some terrific questions here, I'm going to weave in some of these questions with some that we were thinking ahead about, and I'll try to alert the panelists. So Heather, I'm coming toward you first. One of the obvious questions has to do with the unfamiliarity many people have with technologies and generational issues, of course, but I went to medical school, there were no computers, like at all. So how do we prepare patients, families for the use of technology? It's not fair to just say, join me at 2 o'clock and throw them into a technical environment. Could you start with that?
Absolutely. And I want to say hello to everybody and say I'm actually on Treaty 6 territory, homeland of the Métis here in Saskatoon. I'm a patient partner, but I'm also a patient. And why I've been doing this, I've been an advisor and a patient partner for 11 years. And I'm doing this to ensure that no other patients and families experience what I did in healthcare. I did not have a pleasant journey. And so if we can influence or change one person's mind on healthcare engagement, then we've won. So I just wanted to clarify that. But that's a huge question. And I think it's about being open, and as organizations and patients and families, we need to be a bit vulnerable and say, what the heck are you talking about? And so here, I know both with my role with Health Standards Organization and here in Saskatchewan, we've been really mindful to create, if we're going to have a Zoom call with patient partners, we ensure we're sending some information or talk them through how to really connect to that system and some of the issues that could happen, how to rectify it, and how to have a meaningful engagement. Even to say, here's where you tap on to show your videos so you can actually have that human connection. So I think similar goes to that face-to-face with your patients and families. So, you know, ensure that you're talking to your patient. And so I've had many virtual visits, but what's really been lacking is that conversation before to say, is this the right venue for us to be having this conversation, Heather? Is a telephone conversation okay? Or would you rather virtual? Or do you think we need to meet in person? And in allowing us to actually talk through that first and foremost, and then make sure that we have the tools to engage me better. So with my mother-in-law, I'm that segue. And so people connected with me. And so really fun story I'll share real quick is that we were able to check her pacemaker. The clinic said, Heather, do you want to bring her in? Or do you want to just send me a picture of what her site looks like? And I said, let me talk to her. And she said, absolutely, I want to get out of here and see what's going on. So we had the best time. So I cleaned my car, had a mask, and it was a really positive experience. And that all happened because we worked together.
Thanks, Heather. That's great. I think, Susan, I see you'd like to add something to this.
Yes, I think one of the things I wanted to kind of contribute in terms of what Heather's experience is, and it goes to what are the jobs of the future? So right now, when a lot of these virtual visits were being enabled, there was no one at the hospital or in the healthcare system that really thought that was their job to get people connected. So, you know, if you wanted to do a Zoom call when there was no visiting, there was no one obviously that was setting that up at the hospital. It was, you know, added to someone's job. So in the future, I think, you know, these are new jobs that need to be on staff. So whether they're technicians, they're navigators, but they're people that are working with the people that they're connecting and helping them use the new technology. So there's work to do there, but I would definitely say that's a role for the future.
That's a terrific point. It makes me think of something that's visible to all of us right now, and that's the intimacy of virtual. And in a minute, I'm going to ask you, Elise, about this because I think you're interested in this, but I'm peering into your lives. I'm seeing someone who looks like a graduate behind Heather, and I see that Sandy's got some nice art and some books, and Roberta's got an amazing wall hanging or piece of fabric that I'd like to ask about. And so, you know, there's something different about that than being in my office, which I'm in right now in my office looking, you know, and I'm speaking to a patient. Here I am gazing into your home. What about privacy? What about how do we prepare people for this? Could be very positive. We could see some interesting things, but on the other hand, it might be intrusive. Do you have thoughts, Elise, about this aspect?
Yeah, I do. I've thought about this a lot because I think part of the sort of digital divide, if you will, is not just access to internet or access to devices, but it's also access to the privacy that you might wish to have while you're talking with your provider. I mean, I've got several rooms in my dwelling, so I can always escape to one and ensure a degree of privacy. But what if you're, chock-a-block with a bunch of roommates and you want to talk about something that's deeply personal with your physician and you don't want anyone else to know? What do you do? Do you go stand on the corner with your cell phone? I think it can be very intrusive. So that's the downside. The upside is that a physician then gets a snapshot of what the environment is that the patient is actually existing in. And that adds to the sort of ambient information, which might be quite telling, actually. So on the downside part, I think we need to think about providing alternate spaces for people to have privacy when they want to do a virtual call. So I'm thinking, for instance, can we have private rooms in libraries where they can be booked, and you can book it with or without a nurse, say, and that room has a lock. You can lock the door, and there's a computer and there's a phone, and you can undress if you have to and do all of those things which you might not be able to do in your home environment. So I think we need to start thinking about these things in a wider sense. How do we support this other aspect, which is not just I don't have a device or I don't have internet, but also I don't have the privacy I need.
It's very helpful. Yeah, Roberta, go ahead. Oh, I think you might be muted, Roberta. Uh-oh.
Can't hear.
Can you hear me now?
Yes.
Hi.
Ah, bravo.
Technology. Welcome to
We were all waiting. Great, go ahead.
I was going to add to what Alice was saying and Suzanne. I think for me, with working with people online in terms of clients, I support my clients to also kind of get like psychoeducation regarding technology even. So, supporting people to self-monitor, right? So, these are the steps that we are needing to do because we're doing work from home. What's comfortable for you, and kind of work that through in terms of some people might want a video screen or virtual background, not to meet outside. I don't meet outside because I want it to be a confidential space to do a psychotherapy session. So I think in our work we also are teaching our clients or patients to how to be self-empowered and how to have boundaries about how they're going to be in the virtual world. So even having like a class, a patient class or a client class that does that, or a workshop or webinar, I think are things that are really important as we go forward in the virtual world. Yeah.
Thank you. I'd like to, Sandy, go ahead, please.
Maybe just like to add a few things to what's been said. But just actually before I do, Brian, I just wanted to acknowledge your loss. Loss of your mom. And how difficult that must be. And I think if I was your colleague in the hospital environment and we worked together in a compassionate culture, I would have kind of noticed your suffering and come to you and just checked in with you, as to how you're doing. I think that's an important way we can behave. And in this virtual culture, it doesn't really give us that opportunity too much to do that kind of thing. My background is as a palliative care physician, and I provide care in the home, and I provide care on the streets and the homeless. So I think this conversation about the privacy issues is really important. I'm a guest in my patients' homes or wherever they happen to be, where they're at. You develop an intimacy, and you do see, I think like Elise said, you get an incredible background of knowledge. You may see the chaos that's going on with medication and drugs and food and stuff all over the place, or you may see perfect order and contentment. There's a lot that you can learn. And so I think we have, some of us have that intimacy and the ability to do that, to bring it into the virtual world. And I'm thinking of ideas. I mean, acknowledging that and what it means. When we're in spaces where we don't have privacy, we seek and we get those spaces for patients. But in our digital technology, why can't I, provide technology to blur the background or provide a virtual background for the patient that enhances their privacy? It's also the recognition of that. So for the healthcare provider to take note of it and acknowledge the importance of privacy and check in with the patient, and just that acknowledgement, I think, is key to demonstrating some compassionate care and dignified care.
Thank you for your comments, and I do appreciate that. And I do think we struggle with it, but I'm being very touched by people being able to express compassion in virtual ways. And again, just even for this group, I would say it's amazing in 4 or 5 days with relative strangers how you can begin to form some relationships. So I thank you. I would like to stick with the underhoused or the homeless population for a second. There is a question related to this. We've done some of it, but Phyllis in the audience is asking us about this, not only from how we make sure that the technologies are available, but the context in which people live, where you need not only, and I love the library idea, so by the way, that's a fantastic idea, but we also need to be able to deal with the digital record, the virtual platform, the electronic prescription that's going to the pharmacy, the gathering of digital information about your pacemaker. So there are a lot of Canadians underhoused in congregate living settings, also, many of the Indigenous population we've touched on, where the community environment that they're in would really not sustain a lot of the pieces we need. I'd welcome any of you to suggest from a more systems or policy level, how do we start into that? How do we get beyond just the individual advocacy and think about advocating for a different healthcare system? Susan.
I think, like building on Elise's idea, but I think it's the design of the health spaces in the future. And I think they have to drastically change, and we have to start incorporating that, starting with your own hospital, UHN, lots of property. So how do you start incorporating space in there, but to all the local providers? There's literally thousands of healthcare organizations that provide care across the province. And I think they have to look at their design. In my opening comments, I said, let's get rid of waiting rooms. Well, if we get rid of waiting rooms, those can be, private spaces where people can go. Like right now, if you're homeless and you want to get, some attention, you probably have to go in through the emergency. But what are some other options to say that is not the only door I can go in and seek some help and have some privacy?
Yes, Elise, go ahead.
So one of the things I've been thinking about is we have a public highway system. We pay for it through our taxes, and everybody and anybody can use it mostly for free. Why can't we do the same with the internet? Because the internet, access to the internet is becoming more and more a question of equity and justice. And I do believe that we need to start thinking in terms of saying, this must be a public good that's provided out of the public purse for everybody. And that, devices aside, that would at least remove one barrier. It needs to be coupled with access to reliable power, however, which is a challenge for some of the remote communities. So those two elements, I think, need to be in place.
Yeah, Roberta.
So I think it's really important, when we're talking about underhoused or homeless populations, which are populations that I worked with. Yes, it's important to get access and to have a gadget, a phone or a computer. And people used to go to libraries when they were open fully, or go to community health centers to try to access, a client would say like, hey, can I, use the computer for something because I have to send something or whatever. But I think, again, like, your most priority when you're dealing with, being underhoused and homelessness is your homelessness and housing. So again, when we look at, having access to digital platform and what compassion is, well, compassion is having options, accessible, affordable housing, right? For community members to make healthy choices and to have places to rest their head in the night, when they're dealing with health issues in general. So we're in a housing crisis. And I think talking about accessible housing and resources, building affordable housing is a kind of systemic. We need to systemically look at the problems with underhousing and also how folks are being treated within the shelter systems and what resources they're getting and not getting. I think that's even more critical than access to health, the digital health world.
Terrifically important point. Susan in the first session made the point that we may need a paradigm shift as big as the adoption of socialized medicine was in the 60s. And I'm aware that hospitals, including our own, are being challenged to think about social housing and community medicine, and maybe the big H hospital is going to go away. Maybe that's a product of a transient time that we're reinventing. So very helpful. Someone had their hand, I think it was Sandy. Yeah.
I just want to build on that. I mean, it was amazing. Just as we've been trying to get virtual care going for about 10 years in this country, and within about 10 days of COVID, all of a sudden it was exploding. And all of a sudden our many of us who lacked housing were housed, okay? We were able to develop plans almost instantly. But most of my patients all of a sudden had their own motel rooms, were getting 3 meals a day, their own privacy and bathrooms. We can do that for technology, just as they got their rooms. We would have had housing, we wouldn't have had the problem. But now that we did, we were able to scale up and do it. We can provide devices to people. We can pay for data plans as part of healthcare. We can, we've been advocating at the system level for high-speed broadband internet for most of the remote and rural areas of this country where it doesn't exist. We should have free Wi-Fi throughout the city. You know, there are ways that we can do this and make digital healthcare really accessible, get rid of these inequities, and demonstrate that compassion.
It's a great list, a great challenge. We have an excellent question from Vikram in the audience, and this is about the education piece. So there's definitely work to be done for those of us in the system, and all of us online will be in the system for a while, but there's a new generation coming up. And it's very important that the definition of compassion and the understanding is inculcated in the next generation, and that alongside with the technical prowess, they understand the compassion. So the question is, how do we ensure that compassion is reinforced at all levels of training and education at every stage of health professional development? That's a big question, but an important one close to my heart. Heather, let's start with you.
Because it's very passionate for me as well, Brian. I have been working with health science students for probably the past 8 years. And I think our education institutions really need to rethink as well. I've been knocking on doors and saying, I think you need to hear my story and share these lived experiences from patients and families and what they're encountering, to bring back that compassion. And what better with these fresh minds that are so absorbent of what we are having to say and challenging. So I get lots of challenging questions, but that only involves us together to create better. So it's about creating better healthcare providers by partnering with us. So I'd love to see us really challenge the health systems that are educating. And we are getting pockets of that. You know, there's great works happening in BC and the USC, here in Saskatchewan. Quebec through Vincent Demez has the amazing program there. So how do we get that standardized so all patients or all care providers from not just first year, but throughout all levels of education really has that conversation to ground them in that compassionate care?
Thanks for raising that. I do think the work of Vincent and the folks in Montreal is worth shouting out. The idea of patients as teachers, and part of the understanding is that we're all equal in the classroom and everyone is contributing, is really brilliant. So that's terrific. I think I saw a hand. Roberta, was that you? Yeah.
Yes. I just wanted to
look around on the screen. Right?
I think, you know, just echoing Heather, we're talking about lived experiences, right? Having lived experiences in our classrooms, which I bring in all my classrooms and all my trainings or teachings, even within psychotherapy or education. And the question is who are we, which lived experience are we bringing in? So we have to bring, you know, having a health equity lens is critical to compassion. And I go back to the same, you know, the same old kind of record of what is our definition of compassion? Because we can be very compassionate for certain folks and not compassionate for others, right? And that's the problem. So I think that not only that we have different conceptualizations of compassion, but also to teach about practicing it in different ways. You know, my mom taught me, and she passed a couple of years ago, and she taught me, when somebody falls, what do? Well, you put your hand out. Now it's COVID, so you might put a glove on and put your hand out. You know, you put your hand out and you say, hey, can I help you? Are you okay? You know, can you teach compassion and empathy? I struggle with that sometimes. I still try to teach it, but it's also about like deconstructing notions of certain groups of people, right? So we have to talk about health equity and compassion together. It can't be separate for me.
Yes, well, lots of interest, almost everyone. So I think the order I saw them, Elise first, and then Susan, and then Sandy.
Wow, this is a big one, I think. And I just want to pick up on Roberta's question, how do you teach compassion? And tell you a quick story. I was on a working group that we had to design the orientation for frontline staff for the hospital, the local hospital. And we were asked to make it more patient-centered. And we were asked if somebody told a patient story at the front, would that do the trick? And we went, not so much. We need more than that. And we examined what we had in the way of a day and a half's worth of materials that need to be transmitted, and realized they were all task-based. Here's how you do X, here's how you do Y. And there was nothing of what you were talking about, Roberta, compassion for different people. There was no people anywhere in this. It was just death by PowerPoint, 39 different PowerPoint slides on how to do this or that task. So we said, we need to just throw this out and start again. Yes, we need to bring some of that knowledge in, but we need to center it now around people. So we talked with our providers there, and we said, what are the prototypical patients that come to your hospital? And we designed personas, so if you will, fake people, drawing on the experience of who they actually interacted with. And my favorite person was Mr. Abramovich, and he was 88 years old and didn't speak English as a first language. He'd come to this country as a young man. His wife had died, and et cetera, et cetera. And he had a little bio and a picture and everything else. He wasn't a real person, but he felt real. And he was very prototypical of the people in the community that I live in. And then there was Steve, who was 35, a bodybuilder, but he also had mental health issues and happened to be off his meds. And then there was little Joey, who was, 3 years old and broke his leg in the playground. He was screaming his head off with his mom. So the question then became, how do you take blood? What relationship do you need to have with each of these different individuals to take blood? What reinsurances will they need? How do you keep yourself safe in some cases and still do this? So it became all centered around relationships. And that was a hugely, I had such a great experience going through the very first time we delivered that. People were really gobsmacked, and my table spent more time feeling badly for Mr. Abramovich and wondering where his kids were and things like that than they were wondering about how to take his blood. It really triggered the innate compassion that I think many caregivers have, many providers have, and it was very enheartening. So I think it can be taught. It needs to be taught in a thoughtful manner, and it needs to be taught with people who understand and have the lived experience to be able to create the kinds of scenarios that you need for people to wrap their heads around and develop.
And I think, at least from your point, what the extrapolation into technology of your point would be that all the great work that people have been doing with standardized patients and actors and narrative has to be updated for technology. So you're an example. I thought it was terrific. Drawing blood, yes. But maybe the example is, how do you speak to that person through an iPad? You know, the screaming 3-year-old, or the person who doesn't speak English, or the person with mental health. Those are all the exceptions, in fact, to the reasons that I can't do a virtual assessment because it doesn't work. So maybe we should be cautious about thinking about only the situations where the virtual makes a lot of sense and is easy, and look at the challenging situations. There were hands all over the place. I think, Susan, maybe you were indicating, were you, or yes?
Yeah, I just wanted to kind of build on the notion of system leadership, which is part of our session. And, I believe compassion comes from people. So it's people, patients, clients, caregivers, family members. When that voice is absent, I don't think the system talks very much about compassion. So, my background, I worked probably 35 years with health service providers, hospitals, and physicians. And the ministry almost totally designed the system around the providers. What is your advice? What works best for you? How will you get paid? I actually don't see a big change. Like, I'm reflecting back over the last 6 months. I don't see people coming out and saying, this is what patients, this is what families are telling us they want. They're saying this is what the OHA wants. This is what physicians want. This is what the hospitals want. So there's still a very, very ingrained culture that it's the providers that provide the advice. They're the experts. And I would like to see that totally turned around so that we're just hearing more and more. This is what patients have said to us. This is what patients want, like, get an equal voice. Like we have Kathy Fuchs now, a patient ombudsman. The minister's announced her patient and family advisor. Of course, Julie Drury did a fantastic job, but I'm not seeing that. So I don't think you're going to get a system of compassion unless that starts to be equalized.
So Susan, if I could persist on that just for a second, in your former role, you helped me advance some things, and you were passionate, and we get a person like you on side I think Elise called you a mucky muck at one point, and I put myself in that category too, maybe, I don't know. But what's your advice though to foster system change? So we have a lot of agendas right now, and COVID added a whole bunch more agendas. How do we get the attention of and get allies in powerful positions to try to redesign or change the system? How would we do that?
Well, I think it's obviously a very, very difficult challenge, and I don't think it's just by putting one person in. I know Julie very well, and she was one person advocating for change. I think there's lots of local leaders, and I don't support necessarily that there has to be an association or a network, but we have to somehow groom the local leaders so that when say the ministry, politically, locally, there's people that can stand up and speak about the experiences, and there's, kind of a network connection. We're getting that today. So are these people that can come forward and make a stronger voice? And part of it's making it easier for governments of all levels to know who they can reach out to, who's going to give, kind of comments and representation. So it needs some deep thinking, but the government itself, OH, for example, they need to think about how they have a responsibility to get that balancing voice bringing forward.
That's great. Sandy, I know you'd like to make a comment, and while you're at it, maybe you can add in how the CMA and the large national organizations will help too, your advice there.
So to build on the last couple of questions, I think the system needs to recognize how important compassion is, and so how do we do that? I think there's kind of a bottom-up and a top-down approach. So the bottom-up, when we were talking about undergraduate education, we often talk about patients and caregivers co-designing a healthcare system. But what about patients and family caregivers co-designing healthcare curriculums? Why not be there, right there at the school level and all the health sciences and the social sciences, and really have them part of that design, not just appearing in courses or in classes or virtually, but actually co-designing. I think that's one of the ways to go. That's a kind of a bottom-up approach. The top-down, of course, is the compassionate leadership, is creating the cultures that we need. And as I sort of said in my opening remarks, I think people that are in the system need to experience that compassion. Amongst our student population, suicidality, particularly among young women, is about 3 times, what it is for the usual populations. A third of doctors and other providers are extremely depressed. If we provide that kind of, and they're doing it because there's a system that's really harsh on them and difficult. There are many issues that kind of block the delivery of compassionate care, work overload, toxic culture, lack of adequate communication and compassion training for these. So we can, through the leadership that recognizes that, kind of bring it to the fore, bring it to our health science and social science faculties, bring it to our hospital environments. As we should be supporting big organizations. So AMS is starting the conversation in this country about compassionate leadership. The Schwartz Center for Compassionate Care in the US is a major organization, and it's beginning to teach the healthcare community, and might I add, administrators, politicians, et cetera, all about the importance of creating a compassionate healthcare system. So bottom up and top down.
Absolutely. We commented many times that we flipped to virtual care very rapidly. In my hospital, 1 million ambulatory visits a year, 80% were virtual in 2 weeks. But the schools all went virtual too. Every year I teach a death and dying curriculum for the respiratory therapists, and it was just right at the start of COVID, and they said, oh, you can't do it live and in person, you need to do it online. Wow. Role playing with students you don't know, death and dying scenarios online is quite a challenge. But, there's ways we can do it. Roberta, and then I got
Sorry, I just want to say one thing.
No, don't be sorry. This is a great conversation.
I think too, the compassion is important. We need to have it. But again, how do we have compassion when there are different groups who are experiencing oppression systemically and individually within our systems. If you can't see people as human, and we see people as unequal or not the same, then we can't even have a starting point. So we have to address, oppression and, inequities within our system and our healthcare system to even have, I think, to have the basic conversation of having compassion. So I just want to put that out there also.
I'm going to amplify a little bit, Roberta, maybe stay with you and then I'll just for a second, because there's a hot discussion going online that I can see about something called the digital determinants of health. And I like this idea. It's very interesting. We have there's a wonderful speaker, Ruha Benjamin. She has written a great book called Race After Technology, which problematizes technology and through her African-American scientist lens. And she's coming to Toronto to do a lecture soon. And what she has done is looked at areas like genetics and artificial intelligence, and commented that actually the digital world can augment the disparities. And I wonder, maybe because I think the way this is taking place on the chat is, let me pull a formal question here, but do we need to consider and determine and identify a concept of digital determinants of health in order to advance digital healthcare? So I'd be interested in anyone's view on that, maybe starting with Roberta, because you're opening that door for us.
Right. So I think it's a good question. In terms of digital determinants of health, it comes from, social determinants of health, but kind of the digital impact or the digital use of talking about those pieces. And unfortunately, what is often missing, besides, the conversation you just talked about, the scientists, the African-American scientists, is race and racism's impact. So we tend to look at socioeconomic status and how people don't have access to a computer, but without looking at the context of colonization or the context of anti-Black racism or homophobia or sexism or ageism, is I think it's often missing within the kind of digital deterministic perspective. So I rather look at it as from an anti-racist, anti-oppression, or intersectional space, because I think that we then can look at the different factors that people are facing. They're not facing one determinant of health or digital determinant of health. They're actually facing multiple, and they're happening on a daily simultaneously, right? And that's what the intersectionality is. So you could be a Black woman who is dealing with health issues or health access. You might have a disability. You might speak a different language. You might you might come from a queer family. So all of these pieces add stress to your health access. So I think, yes, we can talk about digital determinism, but I think our deterministic approaches, but I think we need to do it from an intersectional approach. And we also have to look at, okay, so this is happening. What is the recall? What's happening with policy? How do the policies actually impact our digital access, right? Is there a connection to that? And I think some of the conversation we've had today open that. But again, it starts with, how do we decolonize ourselves and our own practices in the health work, in the health field, I think.
For the home audience, we don't have a chance to see all the hot chat that's going on. It's being filtered for me. I bet there's a real good conversation going on about this right now. I'll just take a comment we have about 7 minutes. So just for everyone, Elise, I'll take a comment, and then there's another question I want to go to from line.
Okay, I just want to say that code is not neutral. Sometimes we think that software is this sort of neutral thing, but it is absolutely not. And I discovered when I was speaking with Camille Orange, whom many of you may know is prominent person and very interested in diversity. She told me that the readers for passports in the airport don't accurately read Black faces. How come? I mean, that's just astounding. Where were the coders when they were doing this? Did they think everybody had white faces? This is just outrageous. So I think that we need to understand that there is bias built into coding. To Roberta's point, that means that we actually have to get to people who design software, who code software, who test it, who look at prototypes. And we need people to look at those prototypes who come from all different backgrounds and so on. This will become more acute as we move into AI, artificial intelligence, because the biases built into artificial intelligence could create a great deal of harm if we are not really careful. So I think it's a very, very important issue.
Terrific point. I recommend Safia Emoji's book, Algorithms of Oppression, which is really very articulate in this realm, and also Virginia Eubank's Automating Inequality, which is another excellent book that introduces this. So thank you very much for introducing the social science dimension and problematizing what we mean by determinants and participation. That's great. Going back a little bit, but not very far back, but it's a great question. Deborah, this probably jumps off our suggestion that, and maybe it was Susan that started us down this road, that we haven't created jobs or spaces to even do this in our institutions. So she's wondering, Deborah's asking, might there be a role for a formal health advocate or coach in our system to address the digital determinants in access to health and improve the equitable access of patients and families using our systems? That's an interesting question. Thoughts on that?
I would just say yes.
2 thumbs up. Thank you, Deborah.
We have to look at the new roles. So that's a fantastic suggestion.
The panel, everyone's voting, and that sounds like a very popular idea. Yeah, you two are just, Sandy, is that a vote or a comment?
Yeah, it's a vote for yes, but I think we have precedents that we can do. We can teach digital literacy. Once we've made it equitable, once we provided the devices and the data plans, it's like improving health literacy. We have family planning. I've been involved in cancer care and terror for years in sort of developing educational programs for marginalized populations and others to enhance and understand cancer screening, as an example. We can do that digitally. We can have that advocate. We can have those teachers. We can have the counselors and provide people with that ability to learn how to use those devices so that they can connect and have the accessibility. So we've done it before. We can do it with digital devices.
I'll just share with you, we're almost at the end. And just before I turn it to Heather for some final parting comments for the end of a wonderful conference and a terrific panel. The other questions, there were just 2, but they were both about how do we take concrete steps forward? How do we crystallize this? And I think I would go back to the comments at the beginning that this is going to be published into a syllabus that brings together all of these excellent ideas. And I would encourage everybody to think about how do we maybe go home with one concrete thing that we can do tomorrow that will help advance this. It's very easy to get into the clouds and wonderful conferences and then go away and let it fade. But maybe we can each make a commitment to ourselves. That's one thing that we've heard about today that we'll take away, and we'll work on that, or at very least share with others and bring it into the public space. I just wanted to re-articulate again that the sponsors of this conference, AMS Healthcare, is releasing a book on November 18th, and it will echo a lot of these themes. There's a wonderful chapter in it on equity and diversity and its relationship to compassion. There is no compassion without equity. There is a section on compassion and leadership, compassionate institutions and education, etc. So a little bit of promotion, but it's a large group of authors, 25, 30 different authors who have written. It's coming out the 18th from McGill Queen's Press, and it's called Without Compassion, There Is No Healthcare. I hope it's just another way of starting in the conversation that this conference is advancing very, very greatly. So in the last 2 minutes, I want to thank the panelists very warmly for your excellent presentations, your conversation, but also getting to know each of you and sharing and learning something from all of you has been terrific. And I think there's no better way to end a conference on listening to patient and family voices than turning it over to a patient and family advocate for the final word. So Heather, over to you.
Thank you so much, Brian, and thank you to everybody who has joined us for these past 2 days. I'm thinking about that one thing, Brian, that you're asking us, and I'm really thinking about the last session where PJ kind of said, we keep having this conversation about how can we do better? How can we do better? And I know for myself, I think these are the words that came from our CEO here in Saskatchewan, Scott Livingston, when we were transitioning from 12 regions to 1, and we were very worried about that patient voice. And he said, you know what, there's so much I can do as a CEO, and I'm here to listen to you. But go to your MLAs and start making those conversations there. We have so many more patients and families and caregivers and care professionals. Together, we can start a rally and really go and start writing letters to our MLAs to really start doing some advancement in this work. So just my food for thought. So I know I'm going to start an email soon. But I really want to say on behalf of AMS Healthcare and the advisory committee, we would really like to thank you for participating in this conference on hearing your voices. We want to thank all the different moderators and the panelists for their time, their expertise over these past 2 days. And thank you so much for everyone who has joined, because that's a lot of time commitment. But boy, the conversations have been so meaningful. And I know I've made some new friends virtually, so it is we are able to do that. As Brian has said, that AMS is going to publish this report in January 2021. I know I'm going to take that report and share it with all my friends here in Saskatchewan. And I really recommend that others share it in their communities as well, because it's really about working together. If we're going to create sustainable change, we have to do it together. So one final thought, that these have been some very heavy conversations over the past 2 days. And I want us all to really be mindful of ourselves. And because many times we do relive our own experiences from hearing about others who have experienced harm. So I want you to all reach out to someone in your family or friends, or someone that you really trust to speak if you are feeling some confusion or pain. Take care of yourselves, please. So with that, I will end it, but thank you so much for an amazing 2 days, and please take care, be safe, and wear a mask.